The next slide we're going to examine is that of acute graft versus host disease. You'll find this slide in the virtual slide library along the left-hand side of your screen. Go to the section on lichenoid and interface inflammatory reaction patterns, and you will find graft versus host disease. So what do we see on low power? Well, the first finding is that of a little bit of hyperkeratosis within the stratum corneum. The epidermis at this power is mostly unremarkable. Within the papillary dermis, we can see a superficial perivascular and somewhat interface inflammatory infiltrate. Now, as we go to higher power, we can start to see some of the features that are more characteristic of graft versus host disease. The first finding is that of hyperorthokeratosis and at times even parakeratosis. This helps to differentiate graft versus host disease from erythema multiforme. Next, on higher power, we can begin to see that within the epidermis there is a lack of normal maturation of the epidermal keratinocytes, and we're starting to see several dyskeratotic or apoptotic keratinocytes. These cells tend to be localized mostly along the dermal epidermal junction, leading to focal areas of vacuolar change along the basal layer. One finding that is common in graft versus host disease is that these apoptotic or dyskeratotic keratinocytes can also extend down adnexal structures, and we can kind of see that at the edge of this particular specimen. Now, within the dermis, there tends to be a superficial perivascular and interface inflammatory infiltrate composed predominantly of lymphocytes. One of the things that helps to differentiate, say, graft versus host disease from other forms of interface dermatitis such as lupus erythematosus is that in graft versus host disease we don't tend to see attenuation of the epidermis or flattening of the rete as we might see in systemic lupus erythematosus and certainly in discoid lupus erythematosus. In addition, the inflammatory infiltrate tends to be mostly superficial, perivascular, and interface with some lymphocytes extending into the epidermis, whereas lupus will tend to have a deeper inflammatory infiltrate. Another condition to consider in your differential diagnosis would be that of a fixed drug eruption. In fixed drug eruptions, one can also see dyskeratotic or apoptotic keratinocytes along the basal layer, but you tend to have more of a pleomorphic inflammatory infiltrate within the dermis, with occasional neutrophils, plasma cells, and melanophages, cells that are not typical of graft versus host disease. In addition, in a fixed drug eruption, you will often see a superficial and deep inflammatory infiltrate, which again is not typical of graft versus host disease.